If you are a loved one or having surgery, especially plastic surgery or cosmetic surgery, please write everything down that we're going to talk about because I would not want any patient to have to go through what Brooke Shields has come out now so long after her tragic surgery and mishap to happen to you. So, first off, imagine you are having an intimate surgery down in your lower area. There is a woman for pain you've had since childhood. You go to sleep hoping this procedure is going to take care of your pain, and you wake up hours later to find out that, huh, that was done and something else was done as well without you knowing about it. Well, if you're Brooke Jenkins, this is what happened to you, where she went to sleep presumably for a labial reduction, and woke up with that plus a quote vaginal rejuvenation or a vaginal tightening procedure. And the surgeon was so happy to share that, oh, I gave you a little bonus. This will help you feel better, et cetera, et cetera. And if you're feeling like some shock and awe, especially after surgery, there might still be some anesthesia floating around in you. You would perfectly appropriately be feeling that way. And you might also want to take action against something that was done to your body against your consent. I mean, you tell me what you would do. I'm really curious to make sure that I'm not the only one here feeling this way, because this is certainly the response that Brooke had. She wanted to sue. But suing has all sorts of other implications. One, you want to attract more media attention to yourself because it's a pretty sensitive surgery, intimate parts of your body. But number two is that the surgeon here is sharing that, like, he did a favor for you. And Brooke, in her book that she, where she describes her story now, years later, sounds like she must have had some thoughts, some gaslighting, if you will, going on that led to her maybe second guessing. Should I be upset at myself? Was this a favor that he really did to me or not? Well, between that and more attention, potentially getting more attention in the media, many folks might not feel like they could stand up and advocate for themselves and sue. And putting that aside, she ultimately came to the conclusion that shame is no longer an option and we need to prevent this from happening. And that is what I want to share with you. Two big things you need to appreciate about how surgery consent goes so that you can ultimately protect yourself. And we're going to talk about pelvic exams under anesthesia, which are intimately linked to this type of procedure and this concern around informed consent. I know it's a very touchy subject, so just before we get started here, I want to remind you that please keep the comments respectful. I want to address your comments at the end, and I'm going to share how the law works, not necessarily my view, but I will interject my view throughout as well. The goal is for respect, compassion, and you advocating for yourself so you can preserve your dignity and not fall into a shameful situation where you would feel, like Gabby says here, violated for sure. No question about that, Gabby. So let's go to number one of these two things that you need to appreciate as we go through what Brooke says in her book about shame not being an option. This is the scale and stats of when informed consent goes wrong so that you can know when you need to have your radar antenna spinning more than others. Because realistically, informed consent failures don't happen all that often, especially not in such intimate ways. If you're coming in for a tonsillectomy, for a knee arthroscopy, the chance of someone doing a pelvic exam under anesthesia or touching your genitals or your breast is just incredibly rare. We don't have numbers. But what we do know are in cases from the Netherlands and from Australia specifically, where some studies have been published to show what surgeries and what surgeons are more likely to have a complaint levied against them, specifically against informed consent. So in the Netherlands, about 1 in 6 surgeons has some complaint against them for a failure to fully go through the informed consent. But plastic surgeons and orthopedic surgeons are significantly or disproportionately represented in that sample. In Australia, it's a little bit more clear. The stats are about 2x more likely for plastic surgeons to have a complaint against them for lack of informed consent or inadequate informed consent. Overall, these are like 8% in the Netherlands and 11% in Australia of all complaints against physicians. It's like barely double-digit percents. So obviously, it's hugely meaningful if it happens, but overall, it's pretty rare unless you are a plastic surgery patient, in which case it's still likely very rare, but significantly more common because they are disproportionately represented in this sample of complaints against surgeons. So coming from an anesthesiologist, I mean, I've been in over 10,000 procedures and surgeries, and hundreds and hundreds and hundreds of them have been in cosmetic surgeries. This is what I specifically want you to know about how this process works. Because when you are having surgery, you need to sign a piece of paper called a consent form. We jokingly call it a permission slip. And most folks just sign it because they've already talked to their doctor about what's going to happen to their body. And the vast majority of surgeons are good people with good intentions who are just going to do what they tell you they're going to do. However, because of how severe the consequences and how dramatic and traumatizing it can be to have the wrong procedure done on the wrong part of your body, especially in an intimate, sensitive area, it's worth taking a minute to know what you are signing and specifically in what type of setting are you having your surgery, because that will impact the potential for accountability when you sign that consent form. What do I mean by this? If you're having surgery in a hospital, there are so many, and I just want to be clear that I'm not saying that surgeons are bad people. I'm not saying anesthesiologists or doctors are bad people, but I'm saying that there are some realities of life that I want patients to be aware of. I'm not saying that most folks have to be concerned about this happening because it is very rare, but reality is reality. And I don't live in a bubble. I don't live in an ivory tower, and neither do you. So common sense dictates you being aware of this. Common sense fact. In hospital settings, you have many people around you as you are signing your paperwork and as you are having your surgery. If a surgeon were to go against the consent form, which is repeated at the beginning of every surgery, often after the patient falls asleep, so that everyone in the room knows exactly what's happening, someone is likely going to speak up in a giant hospital setting. So I went to medical school at Stanford, residency at Harvard, and these big institutions, people are not going to watch a surgeon do something not in the consent and not speak up. It's just it's statistically very unlikely. There are some exceptions. We'll get to them at the end about pelvic exams, but excuse me, by and large, it's not going to happen there. But there are other surgery settings, especially more common for plastic surgeries, called surgery centers. I personally perform anesthesia in many surgery centers. And these are not giant institutions where there are hundreds of personnel walking around all the time. But unless your surgeon is directly running and owns the surgery center, there is still going to be multiple levels of accountability, nursing staff, other anesthesiologists, other doctors, etc., that are going to be involved in ensuring accountability of auditing of consent procedures. Did the surgeon do what was on the consent? I'm not saying surgeons are not going to do what's on the consent, but I'm just saying that you have multiple eyeballs. This is different when the plastic surgeon owns the center in which they are performing the surgery. Once again, I'm not saying plastic surgeons are wrong to own their own surgery center. It can be cheaper for patients. It can be more efficient. It can even be safer sometimes, I think, because there might just be less red tape and more direct communication between surgeons and their patients in such settings. However, what you need to know is that there might be fewer eyeballs auditing what happens on the written consent and what actually happens. This is where potential bad actors could spiral out or could blossom, and bad things could happen. I don't know. I wasn't Brooke's doctor. I don't know if this is the setting that Brooke had her surgery in, but plastic surgeons, surprise, surprise, are more likely than any other surgeon to have their own surgery center where they're the owner and the surgeon. And you can see now suddenly there might be less scrupulous or fewer eyeballs looking at what actually happens in the room. What this means for you pragmatically is that if your surgeon is doing your plastic surgery or cosmetic surgery at a surgery center that they are the only surgeon in, then you need to be more mindful of advocating for yourself. I'll give you the exact steps in just a minute about ensuring you know exactly what's on the consent, you know exactly what the surgeon is going to do to you, and that you feel comfortable signing that form instead of in the heat of the moment on the day of the morning of your surgery when you're hungry, anxious, afraid of what's going to happen, just signing in a way to get things moving. Because you cannot, and none of this is bad, I want to be very clear, but the reality is that you can't get the relaxing medication until you sign the consent form. How many patients have I seen sign the consent form as fast as possible so they can get their IV relaxing medication from me as their anesthesiologist? A lot. Do I try to pause the brakes or pump the brakes and slow things down? Yes. But like, if the patient's mind is made, there's not much I'm going to do when emotions are running that high. So if you're also having surgery in a surgeon in a surgery center where the surgeon is the sole owner and operator of it, then I would hope that you can sign your consent form before the day of surgery so that you have a minute to review everything on there and make sure there's nothing on there that you were not expecting. So that it's not in the heat of the moment and you getting your relaxing medication, whether it's midazolam or fentanyl or a little bit of propofol or Demerol or whatever it is. Everyone has their own choice as your doctor, but you don't want to be in that crunch time with such a big decision to make. I hope that makes sense, that your setting is key here. As I said, I don't know what happened in Brooke's setting, but I do know from real life practice, even in regulation heaven of California, if you will, that bad things can happen in places where there are fewer eyeballs. So I'm not blaming Brooke for any of this. I'm just simply informing you so that you know when you need to be advocating for yourself and hopefully not fear mongering, but rather giving you the tools to advocate. Number 2 is knowing your rights for informed consent. By the way, a quick shout out that if you appreciate this level of reality of showing you how medicine really works, hit that like button and share with me in the comments below what your experience has been so that others can learn from it so that we can prevent these tragic mistakes from happening in the future. Mistakes, maybe they're intentional, so I can't call them mistakes. Maybe errors or violations or betrayals of trust. And if you are learning something new, please share this with others, especially if they're going to have surgery. So IC, or what I call informed consent, was really fleshed out in 1914 when it was determined that a doctor can be can be accountable in a court of law for unconsented and offensive touching or interaction with a patient. So what does this consent process need? Well, your patient has to have adequate capacity to understand the situation. Makes sense. They have to have enough information about the risks, benefits, and alternatives. What I tell you about all the time, always ask your doctor for the RBA, risks, benefits, alternatives, so that you can make that decision for yourself. And number 3 is that you need to make sure the patient is free of coercion. That wouldn't be helpful, obviously, if you're trying to consent for a procedure. In Brooke's case, I don't know what was exactly written on her consent form. Obviously, I was not her doctor, but this is intricately linked, I should say, with the issue of pelvic exams. How many of you have heard of pelvic exams happening under anesthesia in women who did not consent for the procedure? I'm going to look at the comments here because I want to see who here has heard of it and what their understanding of this real loss of dignity is. You're very welcome, Jody. I'm happy to hear how much you learned, Joey. And hey, Mama Bear, thank you for being a member of the channel. I get to see your comments here more easily than others to answer your questions. So Sue doesn't remember signing anything with the last procedure. I'm sure you did. You must have in the United States to have surgery. Susie says never have heard of unconsented pelvic exams under anesthesia. I'm grateful you have not, but it is a reality. It is fortunately very rare. We're going to talk all about it, but I hear that actually many folks have not heard of it. Janet has heard of it. And Geraldine has heard of it happening. What's going on, Cheryl? Well, we're talking about pelvic exams under anesthesia. I recommend that you watch back from the beginning. I've had pelvic surgery for the 3rd time. Anonymous, I've heard about it. PA has changed. Pennsylvania has changed laws about it. I don't know. I practice in California. I'm going to tell you about the California law in a moment. I'm not familiar with Pennsylvania, but there's a couple of tips that I will share that you all need to know and they're very discreet tips that I want you all to write down. So the point is that many folks here have heard of it. Many have not. Well, a handful have not. Darian has not. So Blessed 316, you have not heard of it. A pelvic exam under anesthesia is when often a medical student might perform a pelvic exam in a patient who did not know they were going to have a pelvic exam performed by a trainee or by a medical student, for example. Maybe it's a nursing student, maybe it's a physician assistant. It can depend on the situation. Usually we're talking about when a patient is having gynecological surgery and the medical student is examining the pelvic area. There's a couple of issues here that make it tremendously challenging, which is why it's persisted for so many decades. But here is the point of California law specifically on this. Now, this is after 1914, where we said that unconsented and offensive behavior is illegal without informed consent. So this is the backdrop after 1914. California, I'm going to read it out to you. You may not perform a pelvic examination on an anesthetized or unconscious female patient unless the patient gave informed consent to the exam or the performance of the exam is within the scope of the surgical procedure or diagnostic examination. I think everyone here would agree that if the woman has given consent and if it's necessary for the procedure, this is okay. The problem is that, at least in California, and I believe other states are going to follow similar, there's no guidance on how to obtain that informed consent. And you can see when informed consent is already such an important issue in sensitive surgeries, if you're not providing guidance on how to do it, it can still be the Wild West. At the end of the day, most women want to know if a trainee or a learner will be performing the pelvic exam under anesthesia, UA. But the problem, this is the key, guys. Take this. This is where legalese and medicalese don't really match. It's unclear legally if potential dignitary harm is the same as what we consider actual harm as a risk of the procedure. So, for example, if in your procedure a uterine artery was cut and you bled, 15 liters and you suffered a stroke from it or something, you don't have 15 liters of blood in your body, but you can imagine a harm of the procedure, a physical harm, that can be legally classified as like a harm occurred to the patient. But dignitary harm is not quite as clear cut. This is a big distinction here. I'm really curious what you guys think about this. I'm going to peek at the comments here because I am very, very curious what your thoughts are. Jane DeBar talking about a dentist. This is I'm going to take this comment off. It's so disgusting. I'm sorry that happened. We're talking specifically about the places in medicine where this is most likely to happen, which is not in the dentist office. It's likely going to happen in these sensitive procedures. So I want to see what people think about dignitary harm versus the physical harm, because I have my opinion I'm going to share with you, but I want to see someone here giving their thoughts. And I understand if you are a little hesitant because it's a tough question, but that's what we're here for, to talk about the tough questions so that you feel more comfortable bringing it up in a challenging situation, potentially, right? If we can talk about it, we make it a little bit less scary. If I have a hip replacement, I don't expect a pelvic exam. Agreed. I am always fine with a trainee properly supervised, but I need to be informed. I agree with that, Andrea. I fully agree with what you're saying. Not that I would ever have a pelvic exam on me, but you know what I mean. My immune system is contradicting itself because I have hypothyroid. Oh, okay, that's exactly what the anesthesiologist said. No, I think you have to throw your dignity out the window when you go in for surgery. Very, very interesting question. Very interesting question. So I'll say that dignity in the form of you're going to be exposed, hopefully as modestly as possible, to the surgery staff. I agree with that. I don't think that our dignity and our wishes and respects, however, should be violated. If our wish and our goal is to receive the care needed to carry out the surgery, then most patients, I suspect, are going to consent to what is needed for that ultimate outcome, as long as there is a reasonable explanation given. This is what I do for my patients. And remember, I am working with patients who have suffered from so much medical gaslighting, often so much trauma, with my ketamine work, with my stellate ganglion block work, for all my other very traumatized patients. I very explicitly go through what the process is to achieve the outcome. And I think when Andrea is saying about dignity, it's sure dignity in maybe the more common sense of exposed body parts, but not that dignity of knowing what's happening to your body to the degree that is reasonable for your doctor understanding. I am very curious about what your thoughts are. And Dale, I appreciate your question about that. Uh, so with this said, I want to end here with the key things that you need to ask. If you take nothing away from this, please take these away, because most folks do want to know about what is happening to their body and how they can prevent unwanted things from happening to their body. Number one, common sense here. If you're having a gynecological procedure, first ask your doctor if there will be any EUA, what we call exam under anesthesia. Many pelvic exams happen without anesthesia, right? The vast majority are happening with an awake woman who can advocate for herself in the moment. This is specifically when there is an unconscious woman who can't speak up for herself and doesn't know what's happening. Sometimes they might wake up and have a feeling that something happened, that they were wrong. That's a whole different discussion of how the body keeps score. But first, you want to ask your doctor. Your doctor is often your biggest advocate. To be very clear, there are a handful of bad actors. The vast majority want to do right by you. Number two, you're going to sign that permission slip, hopefully in advance of the day of surgery. You need to check what is on there, especially for the wording exam under anesthesia. You are not allowed to use abbreviations in consent forms. You are not going to see EUA, but you might see blah, 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 exam under anesthesia. If you see those words, you need to ask your doctor what is being examined under anesthesia and by who. I'm not saying to be aggressive. This is not meant to be rude. It's meant to be for you to stand up for yourself and know what's happening to your body. I'm sure we would all agree with that, but you need to know what to look for. Number three is to ask about students, because sometimes when some institutions have almost like this assumption or an opt-out where the surgery team can include a trainee. If you are very sensitive to a trainee performing part of the surgery, you need to ask your surgeon who will be performing the surgery. I don't believe it is rude to ask. I really don't. I don't think it's annoying. I don't think that you should be offended if you hear that there is a learner, but you should speak up and say whether you do or don't want a student to necessarily be there. You also need to recognize that human beings have to learn from other human beings. And at some point, all medical students have to learn this. I had to learn this as well in the operating room at Stanford on women who consented to us doing this. So women have to, and men have to, at some point, let this happen so that the next generation of learners can learn, because I'm going to get old and die one day. Who's going to take my place? All right. Within this context, if someone has had a history of trauma, and I'm sure many of you listening have, maybe you are not the best individual to have a trainee perform a pelvic exam on you when you're unconscious. And this is why surgery should be taken patient to patient. But I believe the vast majority of patients, like we saw here in the comments, are okay having an exam done under anesthesia as long as they are informed about it. Now, number four is that in your consultation with the surgeon, please bring some reminder for you to ask this question of your surgeon, because in the consultation, guys, I've seen so many of these, and folks have a million questions, and there's only 15 minutes, and they're not going to get through every single one of them. I believe that if you are someone who has a history of trauma or some reason that This violation of dignity could constitute a huge betrayal of trust, which for anyone it would, but some people realistically are going to be more affected than others. Bring a written reminder to ask your surgeon specifically, will there be an EUA? Who will be doing it? And I don't care if you have to put a reminder on your phone to beep, you had to bring a partner with you and have your partner remind you. You got to ask your surgeon. Use any tool needed. Your surgeon should not take offense at this very reasonable question. And number 5, and this is not meant at all to undermine surgeons who have their own surgery centers, absolutely not, but it is meant for you to be comfortable advocating for yourself. If you're having surgery in a surgeon's office or in a surgery center where the surgeon is the only one who owns it and is running it, ask the nurses as well so that you have some confirmation about what we just talked about, what the procedure is, who will be doing it, who else will be in the room. I don't think doctors and nurses are going to have different answers, but if you are that concerned, you deserve to get one more confirmation if you, out there, because otherwise your brain is going to search for negativity, and our brains love finding negative confirmation bias, and you're going to work yourself into a negative spiral before a potentially sensitive surgery, and that negative spiral, that anxiety might torpedo your surgical outcome and your well-being, which none of us would want for you. If you know what I'm talking about, let me know in the comments below. If you learned something new, please share what you have learned with others. And I would really appreciate it if you could subscribe to help me do this more often for you. If you want to join our membership so I can see your questions on here, I would be thrilled as well. But let's get into some of your questions here. I really appreciate on here, Angela telling me not to die. I don't anticipate, I anticipate dying. We all will. And the reality is that someone has to replace me one day. And that's why training the next generation is so important. Ask, ask, ask. Tell me why it's necessary to have one during surgery. When done in a respectful manner, non-aggressive, I think that's very, very reasonable. Negative spiral sounds familiar, Cece. Yeah, if you're a human being, your brain is always looking for negative things. And if you want proof of this, look at news headlines. We know that negative news headlines get so many more clicks. I try not to do this with my content, but it still happens sometimes. And the brain is always seeking control, wants to be in a position of power, and it will seek confirmation bias to justify its negative outlooks. So CC, you are not alone. F Kitty, you are so welcome. When I get back ablations, there are about 8 people working as a team. And it's very unlikely that there will, I should say it's far less likely when there are that many people in the room that there's going to be such a violation. Thank you for the changing mic colors. If you can see that, that's pretty cool. Linda, you're very welcome. Appreciate it, Angela. If a doctor yells at you for a question, he's not a good doctor. You know, Kitty, if anyone is yelling at someone else for, I don't care, for any reason, you got to wonder if you're in a position of power and then you abuse that position of power by yelling, you might, it's not only for doctors, it would be potentially for parents or teachers or any other type of delta in power. You shouldn't be using that by yelling. You should be using that power to guide, respectfully, inspire, motivate, teach. Anyways, I agree. I would probably fire him as well. I think I prefer an exam while I was awake. I'd be fine if it was a student. And Michelle, I appreciate you sharing that because most folks actually feel that way, as long as you're told what to expect. Joey, I'm good to see you on here as well. I don't like people who yell at me either, Austin. I agree. You are very, very welcome, Al Phillips. Thank you for sharing with others. Well said, True Help TV. In California, it's pretty cool, but I don't know about ketamine clinics in Michigan. If there are, there are probably not many. You know, Gene, in California, there are many ketamine clinics. There's just not always the right level of overall care that goes into the holistic experience, which I do not believe things like ketamine can be used in one of these very reductive, non-holistic views because there's risks. And especially when patients are paying out of pocket, I would never want a patient to be reduced to like a body bag of chemicals. You know what I mean? You know, if you agree with me, let me know, because I'm very curious if patients are aware that most doctors are trained in a way that views you as literally a bag of neurochemicals and hormones, and we prescribe medications to push it one way and we expect it to do something else in response. And it's like, there's probably more to it than we understand. I think it's just humility, being honest, that you're probably more than a water bag of chemicals. And ketamine is the classic intervention where if we don't acknowledge the greater existence going on, or at least the presence of more chemicals than we're aware of, we're probably not doing right by the patient. So I don't want to get too meta in here, but I do want to be clear about why ketamine clinics can have problems and why I really want you to, if you are looking for those types of mental health treatments, you got to know what you're looking at. You have to know what red flags to look for, just like we're talking about today. If you want me to do another video on it, I'm more than happy. And thank you for being a member. Daughter, for left in a eval room for 5 hours. I am really sorry to hear that, Anne. If you're comfortable sharing the context, I'm very curious. Oh my gosh, 5 hours. Question asks Humboldt, can you suggest a medicine for a perimenopausal lady with diffuse balding over? Well, it would be inappropriate of me to comment here, not knowing anything about the patient, but you got to wonder if a perimenopausal lady doesn't have perimenopausal hormonal imbalances leading to those conditions. But I can't give medical advice here over social media. I'm being 100% clear on that. I hope that goes better. I think the risks are showing in Musk, well, and many others as well. Wow, I just got one of the best. Someone says I look like I'm 30. Oh my gosh, CJ, you're making me cry on the inside. I'm so happy you're saying that. My skin routine is working. Wonderful. Very good. Very good. Do you have any advice for becoming a medical professional, JR? I have many videos on this. Please watch them before you ever consider going to medical school. The good, the bad, the beautiful, and the ugly are all part of medicine, and you should know what you're getting into. There's a risk to everything. It depends. Yeah, the informed consent is so important, and ketamine is no different. Humility and doctors not go together. Lynn, I hope that I can break that can break that preconception. I know a lot of nasty doctors. I've been wronged by many doctors in the past who have no ounce of humility in them, but I'll say that they're probably the minority. This is coming from someone who's really been hurt by gaslighting jerks out there who have an MD after their name. But it's not what I find the majority to be. Thank you so much for that compliment, the Chance Mom. And wow, you're sharing the story. She went to urgent care for simple illness, but has heart disease. They didn't know what to do with her and just left her there. I'm so sorry to hear that. I hope that others, there's 800 others in this live stream right now. Please hear what Anne is saying, hear what I'm sharing from my perspective. Please advocate for yourself. If done respectfully and from the right place, I don't find other doctors to take offense to this. Biotin is good for hair, Cheryl. I don't use biotin, just FYI. Angela, you are so welcome. Best academic resources for learning on medicine? Google Scholar and PubMed. There's no there's no way to replace you doing your own research at the end of the day. You can always listen to people like myself, and hopefully there's good doctors out there on YouTube. There's lots of other pseudoscience doctors, but at the end of the day, you're responsible for the quality of that education. So I highly recommend you do your own research whenever you safely can. Why do some doctors ignore complaints or symptoms by patients? Mary Jones, very good question. I have whole videos on this, on the pressures of a medical system, an insurance system that do not incentivize doctors listening to patients, and a medical education system that sometimes overplays a reductionistic approach and sometimes undervalues listening to the patient. Not always, but when we zoom out, clearly there is very little, if any, incentive for doctors to spend time listening to patients rather than just try to get through a busy day with 30 patients as quickly as possible, flying through them, prescribing pills and kicking the can down the road, not from a place that they want to do wrong or they want to do harm, but because the system is stacked against patients and doctors. Not against insurance companies, though, but different story on there. Keep going to MDs and surgeons and keep getting these results. It is insane. I am so sorry. I don't know what results you're referring to, but I hope that you are getting a little bit more confidence to advocate for yourself. Can ketamine be used to help someone stop taking Suboxone? Austin, While I have done this, it is not, it is an off-label use of ketamine. Recently, a paper very recently showed very low doses of ketamine infusions helping folks with opioid use disorders, help minimize withdrawals. It's an involved process, requires collaborative approaches. I've done it. I've changed folks' lives, but it's not easy. And it really takes multiple heads being put together to support the patient through their withdrawals and to prevent future relapse. Suboxone is among the hardest opioids to come off of because it is such a potent opioid or mu receptor agonist. It is, if you are on Suboxone, fentanyl may not even touch you because Suboxone is that much more highly competitive, agonizing the mu opioid receptor than even fentanyl is. So therefore, the withdrawals are not easy with Suboxone. I'm wishing you the best if you're talking about yourself here. You're guessing, I like the 30 one a lot better than 43, by the way. And I appreciate that, Lynn. Guys, I want to answer one last question here. I do want to thank Anne again for sharing her daughter's experience. And I'm very sorry about what you went through. I hope everyone here can avoid that level of humiliation by advocating and knowing what settings they need to be more concerned about advocating for themselves in. Let's end with Teresa. Doctors assume everyone is a drug seeker. Unfortunately, many folks do, because the consequences of missing that 1 in 100 drug seeker could be career ending and could be lethal to that patient. I don't think that all doctors think that, but I do agree that many do because of how the system is set up, where it is so punitive for anyone to be giving out prescriptions, punitive on myself, which is why, unfortunately, it harms patients. I'll be honest. I can't treat patients who I would love to treat because of how serious the consequences are of missing that, very small number of folks who are truly drug seeking. Everyone else has to suffer because of it. So Teresa, if you have ideas on how we can solve this and help restore the legal system so that more folks can get the help that they deserve, I would love to hear them. And I'm very curious what others think as well. So please do leave your comments below in the leave your comments below, and you are so welcome. Oh, I'll end with this, Angela. This is such a good question. I read it is rare for someone to not revive after surgery. Is it true? It is very, very, very rare. I have many videos on this. For elective routine surgeries in the United States in particular, it is very rare to not wake up. Usually people don't wake up if they have a massive stroke, a heart attack, or a significant brain injury, maybe from brain surgery where they suffer permanent neurologic deficits. But if you're talking about routine average surgeries, it's just very, very rare. I hope everyone has a good rest of the weekend, and please remember that you have more power over your health than you have ever been told. Until next time.